It's gotten the attention of hospital administrators, clinician leaders, medical directors to say, wow, we've been talking about the quadruple aim and the joy of practice. We didn't realize or didn't think about the fact that it's not just having a pharmacist there to work on workflows, but if we appropriately shift and refer patients who are mostly there for medication management, monitoring, those kinds of things, if we shift them to the pharmacist who's highly trained to do that, working under collaborative practice, we can open up thousands of appointments, which would help with accessibility for patients.
Welcome to the Pharmacy Quality Solutions Quality Corner Show. Buckle up and put your thinking cap on. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. Welcome to the PQS podcast, where we focus on medication use, quality improvement, and how we can utilize pharmacists to improve patient health outcomes. I'm your host, Nick Dorich. Now, for today's episode of the show, I'm really excited to have on a special guest, someone that's been involved with community pharmacy practice and someone that's been a great cheerleader for community pharmacy practice, and that is Marie Smith. I'm going to introduce Marie here in just a second and give her a chance to say hello to everyone. But Dr. Marie Smith, she is the Henry A. Palmer Endowed Professor of Community Pharmacy Practice and Assistant Dean for Pharmacy Practice and Public Policy Partnerships at the University of Connecticut School of Pharmacy. So, Marie, welcome to the show, and how are you doing today?
Hi, Nick. Thanks for having me. Great opportunity to talk about the work that we've done over the years that has culminated in a number of publications that we're going to talk about today, especially the Health Affairs article.
Yeah, absolutely. So as we get started here for everybody, I'm going to give everybody a quick homework assignment if you are listening. We're going to be referring to and really talking about an article that was published on November 13th, 2024 in Health Affairs. It's called Building the Primary Care Workforce with Pharmacist Clinical Services. Now, Marie and a couple other authors were involved in this publication, and I had a great time reading it, as did some of my teammates here at PQS. And we thought, hey, what a great opportunity to talk about what pharmacist and pharmacy can do moving forward. Let's have Marie on to talk about this. So we're going to be doing that today. We're going to be talking about the article. So I would recommend you either pause the podcast now if you're in a position where you can do so. Look up that article. We'll have it in the show notes. Give it a read through, or make sure you listen to it after you listen to the episode. But Marie, before we talk about this publication and talk about what you and your colleagues described, can you tell us a little bit about yourself? What is your background in pharmacy and in healthcare?
Yes, sure. Thanks, Nick. Actually, I started in primary care and ambulatory care as a clinician educator at the University of Tennessee in Memphis. And in this was in the 1980s, which seems like so long ago. But looking back, this was my first job after getting my PharmD degree. And I was in a very unique situation, one that was so innovative at the time, I didn't even realize it. But we had two doctor of pharmacy practitioners, myself and another colleague, and two APRNs who worked in what we'd call today a safety net clinic in the bowels of a inner city hospital serving mostly underserved African-American population. And we did a lot of triage. It was a walk-in clinic. It was meant for people who had just fallen through the cracks, missed an appointment, lost their medications, didn't get refills, whatever. And we had, at that time, what we would now call collaborative practice agreements. We didn't have it as formal then. We were working with an internal medicine physician group, and we would see patients and get them back on their meds, do a quick physical assessment, call in APRNs if we thought it was more of a diagnostic issue. But we really were doing, very early on what we'd call medication management. We would see those patients until they got plugged back into a primary care setting. So that was my first and very innovative practice, working directly in a collaborative practice agreement with APRNs. Subsequent to that, I worked in other academic positions in schools of pharmacy and medicine, worked with family medicine residency programs to teach trainees in family medicine primary care more about medication management, have more of a consultation service with them. And then moved more into the academic side of not doing direct primary care, but working more on health services research for the primary care workforce and payment reform.
Excellent. Well, Marie, thanks for the background there. And I know you and I have met and worked previously talking about primary care items, pharmacist involvement and engagement. I believe you've also done some work with the CMS Innovation Center as well. So if folks have heard or have seen some of your work before, it may be coming from that. But I'm excited to have you on the show today and talking about how pharmacists can be, and pharmacists specifically, pharmacist clinical services can be part of the primary care workforce, which is much needed in our current U.S. healthcare system and environment. So again, as we get started here, this is a health. We're going to be referring and speaking about Marie and colleagues. Their article from November 13th, 2024, published in Health Affairs, is called "Building the Primary Care Workforce with Pharmacist Clinical Services." Marie, ready to jump into our questions for today?
Yes.
Excellent. Well, starting off here, and I always like to start with why. Begins with why. Why are we looking at this? And I think really the big question here is why pharmacist, and why is there this opportunity for pharmacists? So, specifically what I want to start off with here, pharmacist engagement, pharmacist involvement for care teams. Why is this a topic that is being, or that has been discussed, and why is it continuing to be discussed? What is it about the current environment that is inviting this conversation? Are there aspects of it specifically to pharmacist training that are new, or is this more so just simply the environment that we are seeing from a primary care standpoint?
So I think there are two main reasons why this is a top of mind discussion today, Nick. One is for a long time now, we've known that there's a primary care physician shortage. And secondly, there are very long wait times for patients to get primary care appointments. So I'll talk about them. The first one on the primary care physician shortage. Several reports have come out in the last few years trying to get a handle on estimating what is the kind of scope of this shortage. And the latest report says it's somewhere between 20,000 and 40,000 primary care physicians are needed by 2036, more than we will have coming through the pipeline. And another report kind of gave it a different twist. And this is the Health of U.S. Primary Care 2024 scorecard report that came out last year. And it talked about the primary care workforce not growing fast enough to meet population needs, where we are all getting older. We have people with multiple comorbidities and chronic diseases. Many of them are going to be dependent on medication therapy. So the number of primary care physicians per capita has declined over time. And the share of all primary care clinicians, that includes physicians, nurse practitioners, PAs who are working in primary care settings, has really been stagnant. It's also been reported that even for those medical students who do pursue primary care residencies, only about 15% of them are still practicing primary care 3 to 5 years after they complete their residency. So that kind of is kind of a stark wake up to say, the primary care workforce needs to be more creative in looking at who are the team members and how can we expand those team members. The second part of that is these long wait times. I don't know if you or any of your listeners or their family members have tried to get primary care appointments, not with an established practitioner, but if you've had a move or you're trying to change, the practice you go to, or your insurance doesn't cover who you went to, and you have to look for a new primary care practitioner. We have in our family, we've got situations where it took 6 to 12 months to get an appointment with a primary care provider. So those long wait times are real to people. And we actually did a little bit of research here as part of a CMMI grant that came to the Connecticut Office of Health Strategy. And we did that a couple of years ago. And we looked at estimating the amount of PCP, primary care physician time saved by having a pharmacist integrated with the primary care team. And we did this in two places. We did it in a health system affiliated primary care group, which saw mostly working adults, people who had insurance. And we also conducted it in a federally qualified health center where you're serving more underserved, you know, population. And what we came up with is on an annual basis, one full-time equivalent of an embedded pharmacist meaning a pharmacist that practices in the office, is a visible daily team member of that primary care practice. When they are embedded using a collaborative practice agreement, it can save up to 640 physician hours per year by shifting those responsibilities to the pharmacist for medication management, and it results in simplified workflows for that primary care physician. So that's time saved of the physician, which is great, but more importantly, we can translate that time by saying how many appointments could the physician see, and if those hours were freed up, and would that help us, be able to get patients in sooner, and especially for more urgent issues and new patients. And that equivalent is the one-time, full-time equivalent of the embedded pharmacist can open up approximately 1,900 primary care physician visit appointments per year. So that's amazing. And that really is when we've reported here in meetings locally in Connecticut, it's gotten the attention of hospital administrators, clinician leaders, medical directors to say, wow, we've been talking about the quadruple aim and the joy of practice. We didn't realize or didn't think about the fact that it's not just having a pharmacist there to work on workflows, but if we appropriately shift and refer patients who are mostly there for medication management, monitoring, those kinds of things, if we shift them to the pharmacist who's highly trained to do that, working under collaborative practice, we can open up thousands of appointments, which would help with accessibility for patients. So I think those are the two big factors that I think are top of mind as to why this is a pertinent and current discussion topic.
Yeah, Marie, it's great, and I appreciate you going through the situation in the current environment. I think you explained it well. You talked about being able to find doctors or get appointments, and I can say my own personal example, and it's one anecdote, right? Not necessarily the case for everybody, but when switching insurance, 8 months to get a primary care visit under my right, finding a doctor that's in network that's going to be paid or covered for the service, 8 months, from that part. So that's an example there where someone looking or trying to seek out preventative care or just regular maintenance, right? It shouldn't take that long. So that's one such example of the situation what we're covering in. But as you explained there, we're not asking, when I say this, we as the pharmacy community are not necessarily asking that we're wanting pharmacists to do more or saying something that's out of a scope of practice. We're talking about here, as you said, managing medications and doing activities that are within the pharmacist's expertise, within the pharmacist's scope of training, and often items that whether or not they can be billed directly by a pharmacist, they're often going to be items that can be covered under billing for a location or through collaborative practice agreements or other avenues. So this is a part here where it is somewhat of a change in practice and to some degree a change in expectations for providers or other parts of the healthcare system, and maybe to some extent for the patients themselves. But this is something where it really should be an easy kind of layup, if you will, to get pharmacists involved. With that, Marie, I want to dive into this next item and say, okay, we kind of talked broadly about this, what pharmacists can do and what pharmacists are trained for, but what are some of the the service opportunities, the patient care services that can be or should be delivered by pharmacists as part of this primary care team? If you have any particular examples where your work and research has referred to specific examples that have shown to really produce good ROI or improving outcomes, those would be great. But where would you point people to? What are some of these services that pharmacists should be taking over and managing as part of the primary care workforce?
Sure. So I think the most of your listeners are going to be able to understand that and know that a little bit about the pharmacist training. But when we think about it, the pharmacists are highly trained yet grossly underutilized part of the healthcare workforce in the community. And they really can, as I mentioned, fill the gap in this physician shortage, especially when it comes to medication management and monitoring for chronic diseases that are dependent mostly on their therapy plans are around medical treatment. Couple of our co-authors on some of our work have Tom Bodenheimer and Kevin Grumbach out in San Francisco have done a lot of work on primary care teams and talked about, what is this ideal primary care team? And it really should incorporate healthcare practitioners who have complementary skills to those of physicians. So including us as pharmacists, where we can help achieve high quality patient outcomes and improve physician productivity that we talked about. It's estimated that about 37% of the time of a primary care physician is spent on activities related to chronic care management. And a lot of these are this time both in the office visit, looking at refill requests, interpreting lab values to make changes in a patient's medication therapy plan, will include things that are well within the wheelhouse and training of a pharmacist. So the types of primary care services could be something starting out as simple as, some of our work and work of others has shown how many medication discrepancies there are between what the patient is using at home and actually doing at home, what the patient's intended therapy was as ordered in the electronic health record or documented in the electronic health record. When you have an embedded pharmacist in the primary care office, they can spend the time to go over and do a very comprehensive, medication reconciliation, looking at what's the best actual list of medications that are being taken at home, and can provide anything that comes up with a discrepancy, can correct that. So that would be just the simplest thing to do. But once a pharmacist is actually in the office, can work with the patient directly, doesn't need to involve the physician time if it's a collaborative practice arrangement. There are various types of services that can be provided by the pharmacist as long as they are within the scope of practice. And so that's going to really vary by state. Each state's going to regulate what they consider the scope of practice for pharmacists. And just to give you some idea, this was kind of dovetails with what we talked about in the article. There are states that allow what we'll call full or broad scope of practice, meaning it allows the pharmacist to perform any service that's covered under that state's scope of practice. And then there are other states that would really have a more limited scope of practice. And that would be usually what we think of as state protocols. So let's talk about the first one. When the state does allow broad scope of practice, this includes any topic, any service that would be considered within that scope of practice to be performed in that as a member of that primary care team. And just to give you the listeners a little bit of a reference point, there are 10 states where both Medicaid and commercial health plans allow broad scope of services, 7 states where only Medicaid allows the broad scope of services, and 7 states, different states where you have only commercial health plans allowing broad scope of services. So there are a number of states that do allow a very broad scope of service. Most of the time, if you have a embedded pharmacist in a primary care practice, they're going to be involving a collaborative practice agreement between the pharmacist and primary care physicians. Some states will allow that collaborative practice with APRNs, nurse practitioners as well. And these collaborative practice agreements will define specifically the responsibilities of what's delegated to the pharmacist. So some examples could be developing a medication treatment plan based on the physician's diagnosis. It could start with selecting and initiating a new medication or adjusting a medication of a dosage where the patient's been on a medication, but the therapeutic outcome hasn't really been achieved, and it needs someone to spend a little bit more time and attention looking at how to titrate and adjust those medication dosages and monitor that. Or it could be ordering and interpreting a lab value test result to monitor chronic disease medication. So those are some examples of services under full broad scope of practice. For those states, there are about 19 states that have more of what we call limited scope of practice. Usually, those states operate on what we call statewide protocols. So, the state regulatory agency has put out um, a service, a specific service, type of service that allows the pharmacist to be involved for very specific things, like some examples of hormonal contraceptive prescribing, or certainly we all went through the COVID test and treat, naloxone prescribing. It could be HIV PrEP and PEP, smoking cessation. So they are very discrete services, certain kinds of populations that you have the authority to work with in a limited scope of practice. So I think that will give you a good overview of how it varies state by state. And for your listeners, it'd be good to check in with your state board of pharmacy and find out kind of what they do allow. Do they allow full broad scope of practice for a number of services, or it could be, and they may also have limited scope of practice that are targeted for certain kinds of pharmacist services.
Yeah, State Board of Pharmacy, a good place to check. Maria, I'd also recommend for any of the listeners as well. NASPA has great resources and information
Yes.
on what's happening in the states, and this is often a rapidly, and especially you mentioned since COVID, there's between test and treat and some of the other services that can be provided. It's also been a rapidly evolving and changing landscape. So even if you were familiar with what you could do last year in your state based upon your pharmacist license and working, that could be subject to change. And I know NASPA and some of the other groups have resources or templates or other things like that that can help to create some of these legislative changes in the state that you're working with. Marie, appreciate the rundown and covering what we're talking about, what you talked about as far as services. Just as you were speaking, I was kind of just taking some notes on the side of my desk here, looking through it. And I graduated pharmacy school in 2011, and just about everything that you covered as part of the curriculum, even now almost 15 years ago, that I went through in school. Now, I'm not necessarily the pharmacist qualified, being a bit out of practice myself, but at least coming from that perspective on, hey, is the pharmacist workforce ready and able? Certainly there's going to be in some institutions or some collaborative practice, other groups may have some other training requirements, certificates, other things like that may be involved. So that could be subject to some variation, but this is an area where pharmacists are ready and able generally to be able to provide these services. Now, Marie, the last thing that we kind of want to talk about, and it's an important one, because this work and this work that can be done by pharmacists, it does come down to pharmacist time. It does come down to how this can be implemented with a health system, and ultimately it needs to be ensuring that not just that this work is being done, but that work is being, and that time that is being paid for. So are there models or methods in place that are being tested, or perhaps that are already implemented, that cover, for a pharmacist time and involvement with these types of operations and with their engagement as part of that primary care workforce?
Yeah, that's a great question. And, even today in my teaching role, there is a kind of myth in many ways on the part of students and practitioners that we really are limited because we don't have any kind of reimbursement for our services. And
Right.
that's a little bit of what sort of, was sort of in the back of my mind when we started to write the health affairs article, is to say, okay, we hear, we go to national meetings and we'll hear a speaker talk about, what they're doing in their state. And yet we didn't really think there was a great amount of information out there for pharmacists alone, never mind healthcare policymakers and other healthcare professionals, about what really is happening on a broader scope across the country. And we have little pockets we know of. But so that kind of, made us kind of look at this idea of what does the payment landscape look like for pharmacists? And we were pleasantly surprised that there are 41 states that do allow some degree of payment for pharmacist services. So it might be just one payer. It might be just for a limited service, like just for COVID, test and treat, or just for hormonal contraception. But 41 states have recognized that pharmacist services are able to be allowed within scope of services, and there's some payment mechanism for that. The caveat, so that's exciting news, 41 out of 50 or 51 if you count District of Columbia. The sad part of that is it's not pervasive. It's just for one service or a limited number of services. Or it could be that it's just one payer or something like that. And most importantly, as our listeners, I'm sure know, we've been talking here about states that cover for Medicaid and commercial health payers, but the largest health payer is Medicare, and we're all struggling professionally to try to get over the finish line there for Medicare to recognize the talents and the services and the positive patient outcomes, and I believe cost savings that pharmacists can provide, so that Medicare will provide and allow us to have some provider status for payment as well. So good news is there are a lot of states that do allow some degree. Opportunity is that we've got to get it more pervasive across beyond Medicaid or commercial and beyond just for certain services, but have it for broad coverage for all services. And we need to really still work on the Medicare piece. So you mentioned, you asked other examples today, and I'll offer a few. So let's take Medicaid as the healthcare payer. Hormonal contraceptive prescribing is now allowed in about, I want to say, it's probably upwards of 25 to 30 states have pharmacist services for hormonal contraceptive prescribing. Many states allow it. However, the downside is they allow it professionally, but they haven't put in a payment mechanism, so that's going to hinder what ability we have. And we in Connecticut face that. We have had for the last couple of years, we had a bill passed. We now have authorization and regulations in place. We have a training program in place. We have no payment mechanism. So it's going to really hinder the anticipated effect and public health benefit, I believe, for what we can do. But in some states, California, Maryland, Oregon, Nevada come to mind, they have active Medicaid programs to not only allow for hormonal contraceptive prescribing, but to pay for it. And the payment is structured very similar, and you follow most of the mechanisms of payment requirements for physicians or other healthcare practitioners who are paid by, a health payer. So you have to go through a credentialing process, and you need to sign up for, making sure you're on the provider registry, and you have to go through all those things. But they have negotiated payments for hormonal contraceptive in those 4 states, and they vary by state, as you would imagine. They're all negotiated, but the payment for an initial encounter when a patient first comes into a pharmacy for hormonal contraceptive prescribing, that's going to take a little bit of time to do a patient assessment, go over kind of a history, find out what's the patient's been using in the past. So it's going to take time, do blood pressure checks, those sort of things. That initial encounter could take anywhere from 30 to 45 minutes. And in those 4 states, California, Maryland, Oregon, and Nevada, those initial patient encounter payments range from $39 to $74. And then they also have a second payment structure for any kind of follow-up, meaning existing patient encounters. And those won't take as much time, so the payment ranges there from about $18 to $41. So that's an example for hormonal contraceptives. One state that really has had a long history of payment by Medicaid is Minnesota Medicaid, and they have had medication therapy management payment, I think since probably 2006, 2007. It's been quite a while. They have used specifically the MTM codes, the 99605 to 99607, which are time-based codes. And that Medicaid program has payments, again, based on whether you're a new patient or an existing patient. But the new patient ranges from $52 to $148 for that initial patient encounter, with a pharmacist, depending on the number and complexity of drug therapy problems that the pharmacist is going to address. And then for payments for any follow-up or existing patients for follow-up appointments, they would usually be working on something that has already been identified and monitoring. So those are a little bit less. They range from $34 to $130, again, depending on the number and complexity of the drug therapy problems to follow up. So that's an example of things that have been going on, are happening today and been going on in Medicaid in some states. Commercial payers, most commercial payers use a billing code similar to that of primary care physicians and will pay the pharmacist the similar rates to primary care physicians. There are some states that have, or some plans, which try to negotiate that we should be paid not at the physician rate, but more at the mid-level provider, the APRN or the PA rate. And I'm not a big fan of that. And I know about a year ago, Michael Hogue, who's the CEO of APHA, came to visit us at UCONN, and we had a great discussion about this. And he said that he was advocating that as a profession, we should be stand fast on getting reimbursed at the same level of the physician. And I forget which state he had been in, but he talked about how in one state, a physician said, when I refer a patient to a specialist or to a pharmacist, I'm doing that because they have a skill set that is able to be used that's different from mine. I spend most of my time on diagnostics. When I refer a patient or a patient sees somebody who's a mid-level practitioner, it's mostly to do things that are an extension of my skills. And so, yes, there might have been a negotiation of wanting to, do something along the lines of 85% of payment or something like that, just for competitive purposes or whatever. But when I send a patient and refer a patient to another practitioner outside of an APRN or a PA who's doing similar scope of work to what I do, I expect them to be paid 100% of whatever that going rate is, if I had to do it. So that's, I think, a caveat we should keep in mind is there may be, these situations, but try to see if you can get parity with what physicians are paid. The most common billing codes that are used would be for patients who are existing patients. So you're not seeing them new. They've been to the physician. They've got a diagnosis. You are now seeing them to develop or to manage a treatment plan. And those codes are similar to what primary care physicians would use, the CPT codes of 99211 to 99215, again, based on complexity of medication or medical decision making. So those payments are negotiated. We don't have a way to go in and find out, what those are, like we do in a public domain like Medicaid. So they can be negotiated and proprietary, but usually commercial payment would be a little bit higher than Medicaid as well. So that might be just a relative scale to use. So those are some examples of existing programs that are going on now.
And I agree, Maria, when you let off your comments talking about how there's the idea that you often hear or see when you're teaching that, well, pharmacists can't do these things because we don't have the payment that's there. There are enough models or enough examples where this, has been done. As you pointed out, would be great if Medicare was paying pharmacists like it does other providers to be able to do these sort of items. But addressing that, it's one item, and that would certainly open up the floodgates. But that also comes with its own challenges and own unique, scenarios around billing and management. But there's enough examples that we see in different states and different programs, right? And it's an item that I know I've said and that I've shared with others, previously is, if you're a pharmacist or a pharmacy team looking to engage with some of these programs, either with a health system or with a payer specifically, or heck, even an employer group, there's ways that if you're providing a valuable service that, you can set up some form of direct billing or direct payment to be able to account for these. And I think we do see enough examples of that occurring. It's a part there where I think pharmacy, we need to step a little bit outside of our comfort zone and somewhat selling ourselves and selling the value and the worth and the ROI that's there. But there's certainly enough examples to show that adding or including a pharmacist for these tasks that are very much part of the education, the training, and the experience are worthwhile, not just for the hospital, the health system, and the providers, but most importantly and ultimately for the patients receiving the care. So, Marie, with this, I'm going to kind of wrap us up as far as this conversation discussion on pharmacist involvement with the primary care workforce. But you're still working in this area. So are you able to give us any kind of sneak peek or an idea on, hey, what you and, I know you worked with a couple other authors on this that was published in Health Affairs. But is there any kind of, next step or next phase that you're looking to address, both for pharmacy, but more broadly for those that are involved with public health and being engaged with innovative practice models?
So, yeah, I think, first of all, it was surprising to us, as I mentioned, to see when we really had the landscape of what was going on in the states across the country, to see that there are some very, very great models that we can build on. So I think what we are focusing on now is to get that word out, like the Health Affairs article being one. We have some other work that we've done here in Connecticut, where we surveyed primary care practitioners, physicians, and APRNs mostly, to just see, how comfortable would they be with these scenarios of pharmacists working either in a community setting where they could monitor the patient. We know that the community pharmacist sees a patient probably between 5 to maybe as many as 10 times more than the patient will see their primary care practitioner. So they have a lot of access in the community pharmacy setting. And what would they be willing to incorporate into like a more community-based practice model? We were glad to see that as long as they had the correct training and it was within scope of service, most clinicians who are in primary care would welcome pharmacists in community being part of their team logistically. I think the things that we noticed that still need to be worked on is trying to get access in the community pharmacy to the electronic health records, whether that's directly through like being part of a network in your community, or perhaps your state has a health information exchange, so you could at least see some of that medical information about the patient. So that's one thing I think that can be worked on. I think the other thing would be that as practitioners ourselves, we need to not only educate, we think of policymakers and things like that, but just getting out and maybe speaking in our local communities, going to monthly state medical meetings, medical society meetings, and being kind of advocates to let them know. Many of them don't know still. It's amazing, but they don't know what our training is. They know what it was when they practiced or when they were training. They saw pharmacists in hospitals, and they have no concept of what we can do and what is going on in the community setting, out in the ambulatory setting, outside of a hospital environment. And then I think thirdly, we need to think about, we can be great advocates with our state pharmacy associations and our schools of pharmacy, our boards of pharmacy at our state levels, to make sure that we make them aware of what other states are doing, and not only just allowing it in scope of practice, but having a payment mechanism. I think without having the payment mechanism built in, we're going to see very, very underutilization of what authority we have as licensed healthcare practitioners. There's just not going to be the uptake if we don't have a payment model built with it. So those are some thoughts that I can end with.
Yeah, we've certainly we've covered the payment part, and we've had some different folks. I think back more than a couple episodes, Julie Akers from the state of Washington spoke about that, where Washington is considered one of those more progressive states and allowing pharmacists to do a whole lot. But if the payment mechanisms aren't set up there, it makes it a lot more difficult to get the ball rolling on these scenarios.
Yes. Yeah.
So, Marie, with that, and appreciate having you here on the episode today. And as we wrap up, folks may have questions or may have follow-ups, and they want to learn more about some of the examples or some of the states that you kind of talked about here. Is there a good way to reach out to you? Can they find you on LinkedIn? Anywhere else you can share? And or are there any other conferences or events where you're going to be covering this topic and more, coming up in the not so distant future?
Yeah, thanks. So, yes, if there are questions, I can be reached certainly first at the University of Connecticut School of Pharmacy. Very simple email, Marie, Marie.Smith, SMITH, at UCONN.edu. So that's one way. Also, I'm pretty active on LinkedIn. So that's another way. And yes, actually, the Virginia Commonwealth University School of Pharmacy and UCONN School of Pharmacy are doing an invitational conference. So it's not open to the general public, but we are doing an invitational conference in the beginning of March that is specifically on state Medicaid programs and to share the kind of trials and tribulations and strategies and examples of value-added services and value propositions of having pharmacists. And it'll include states that have had Medicaid programs, both full scope of practice and some limited ones, talking to other state leaders. So this will be mostly for policymakers, state Medicaid administrators, pharmacy leaders, maybe medical directors, as well as some of our, health plan colleagues to share a little bit more. So I think that those are all ways that and I would encourage those of you in your own states, if you've got programs in place, try to get out and educate your physician colleagues as well about what you're doing, because many times they just aren't aware of what is happening. And if you still need to get payment in place, then look for them to advocate for you. It's always better when we have other professions advocating for our services.
Other professions are, of course, patients being the other one. Patient advocates are huge in that regard as well. Well, Marie, thank you very much for the time today. And again, for everybody, we've referenced it a couple of times, but it's Health Affairs article, Building the Primary Care Workforce with Pharmacist Clinical Services. We've got author Marie Smith. Marie, I'll shout out your other colleagues on the article as well, Thomas Bodenheimer and Kyle Robb. So this is really, a great article and a great opportunity to highlight the opportunity that pharmacists and pharmacy has to contribute to public health and to the primary care workforce, something that is, as you explained, we need more of that. So recommend for everybody, go check out this article. If you have questions or other follow-up, certainly engage with Marie. Take a look at what your state pharmacy association has as far as resources and ways that you can kind of get involved and work with payers and health systems to be engaged on this. And we look forward to a positive opportunity for pharmacy, but most importantly for patients as we go forward. With that does mean for our audience that we have wrapped up today's episode. And we thank you for your time and listening into another episode of the Quality Corner Show. We hope you listen to our next episode. And then before we go, we have one final message from the PQS team.
The Pharmacy Quality Solutions Quality Corner Show has a request for you. Our goal is to spread the word about how quality measurement can help improve health outcomes, and we need your help in sharing this podcast to friends and colleagues in the healthcare industry. We also want you to provide feedback, ask us questions, and suggest health topics you'd like to see covered. If you are a health expert and you want to contribute to the show or even talk on the show, please contact us. You can email info@pharmacyquality.com. Let us know what is on your mind, what we can address, so that you are fully informed. We want you to be able to provide the best care for your patients and members, and we wish all of you listeners out there well.